Welcome to this MediByte explainer. I'm so thrilled you're joining us today. As a healthcare professional, I completely get that stepping into the world of labor and delivery can sometimes feel like trying to read a medical textbook in a totally foreign language, right? There is just so much jargon, and honestly, it's incredibly easy to get bogged down by all the scary what-ifs. But that is exactly why we are here today. We are going to decode that terminology, break it down, and completely demystify the complications that can pop up during labor and delivery. By the end of this explainer, you're going to have a rock-solid understanding of exactly what goes on, which will really empower you to navigate this whole journey with confidence. Okay, let's dive right in. Here's our roadmap for today. We'll start with the timing of labor, then we'll break down the physical mechanics of fetal presentation and position. From there, we'll look at common variations in that positioning, review some unexpected complications, and finally wrap up with the medical interventions used to safely resolve them. So, starting off with Section 1, the timing of labor. To really understand complications, we first have to establish the baseline. So let's look at how we actually frame the due date. The average length of a pregnancy is 40 weeks, and we count that from the first day of the last menstrual period. But listen, that 40-week mark, it's really just an estimate. Most people do not deliver exactly on their due date. However, the timing absolutely does matter. If labor kicks in before the 37th week, it's considered preterm. If it holds off until way after the 42nd week, it's postterm. Delivering outside of that sweet spot carries some increased health risks for the baby. And sometimes, this early or late labor is actually triggered by an underlying medical problem, or even just by how the fetus is positioned inside the uterus. Which brings us to Section 2, fetal presentation and position. As you get toward the very end of pregnancy, the baby has a lot less room to move around and usually settles into one primary spot. First up, we have what we call presentation. This simply refers to the part of the fetus's body that's literally leading the way down the birth canal. You can think of it as the presenting part. Usually, thank goodness, it's the head leading the charge, but sometimes it can actually be the buttocks, a shoulder, or even the face. Next up is position. This describes which way the baby is facing relative to the mother. To get just a little bit technical here, the occiput is a bone at the very back of the baby's head. If the baby is facing backward, meaning they are facing the mother's back, that's called occiput anterior. If the baby is facing forward, looking toward the mother's pubic bone, that's called occiput posterior. And finally, we have the lie. Think of this as the overall angle of the fetus in relation to the mother's spine. A totally normal lie is longitudinal, meaning the baby's spine is perfectly parallel to the mother's spine in a straight up and down orientation. But occasionally, the baby might be lying completely sideways, which is a transverse lie, or at a weird diagonal angle, which we call oblique. So when you put all of those terms together, we arrive at the absolute safest, most common, and frankly easiest combination for a vaginal delivery. We want the baby head first, which is a cephalic presentation. We want them facing backward in that occiput anterior position. We want a parallel, longitudinal lie, and ideally the baby's neck is flexed forward with their chin tucked right into their chest and their arms folded neatly across their body. This makes them a little aerodynamic package, which makes navigating the birth canal so much easier. But you know, nature loves to throw a curveball, doesn't it? So what exactly happens when a baby decides not to settle into this perfect, optimal position? That leads us perfectly into Section 3, common positioning variations. One of the most frequent variations we see is the occiput posterior position, affectionately known in the delivery room as sunny side up. The baby is still head first, but they are facing forward. Now, this isn't necessarily abnormal at all, but it definitely makes delivery more challenging. Why? Well, because when a baby faces up, their neck often straightens out rather than bending nicely forward. And a straightened neck physically requires more room for the head to pass through the pelvis. Because of this tighter squeeze, mothers might need just a little extra help during delivery, like the use of a vacuum device, forceps, or in some cases, going ahead with a cesarean delivery. Then we have the breech presentation. This is where the buttocks or feet are leading the way. Now, this is significantly riskier. The physical mechanics here are totally crucial to understand. A baby's hips and buttocks are simply not as wide as their head. So if the buttocks pass through the cervix first, the passageway might not be stretched wide enough for the head to easily follow. If the head gets trapped in the birth canal, it puts immediate dangerous pressure on the umbilical cord. This can severely limit the baby's oxygen supply, elevating the risk of brain damage or even death. And that right there is exactly why doctors take a breech presentation so incredibly seriously. You might be wondering, well, why do these variations happen in the first place? Well, they're much more likely to occur if labor starts too soon, before the baby has even had a chance to flip. They're also super common in multiple gestations, like twins, just because space in there is so limited. Other factors include an abnormally shaped uterus, the presence of uterine fibroid growths, certain fetal birth defects, or a situation called fetopelvic disproportion. That's just a fancy way of saying the fetus is just a bit too large for the mother's pelvis. But listen, if your baby is breech, please don't panic. Modern medicine has some incredible techniques to handle this, like the external cephalic version. If a baby is breech around 37 or 38 weeks, a doctor can sometimes literally turn the baby manually from the outside. They might give a medication like terbutaline to relax the uterus and stop any contractions. Then, using an ultrasound to guide them, the doctor applies firm pressure to the abdomen to physically guide the baby into a head-first position before labor even starts. It is a fascinating, hands-on, and often very successful procedure. There are a few other rarer presentations out there. In a face presentation, the baby's neck arches so far back that their face actually enters the canal first. A brow presentation is pretty similar, just with the forehead leading. The good news here is babies actually often correct these positions completely on their own before labor gets too far along. However, a transverse lie, where the baby is lying completely horizontally across the birth canal, almost always requires a scheduled cesarean delivery, unless it's the second baby in a set of twins being delivered by a highly experienced doctor. Moving on to Section 4. Unexpected labor complications. Okay, so even if the baby is in the absolute perfect position, unpredictable things can still happen. The crucial thing to remember is that while labor usually goes totally smoothly, some issues can develop very suddenly. These include intraamniotic infections, which cause inflammation of the tissues around the fetus. There's also shoulder dystocia. This is where the baby's head is delivered, but their shoulder gets caught tightly against the mother's pubic bone. We also keep a close eye out for umbilical cord prolapse, where the cord actually slips out before the baby, and uterine rupture, which is a severe, but thankfully very, very rare, tearing of the uterus. A few other sudden complications include amniotic fluid embolism. This is a rare event where amniotic fluid actually enters the mother's bloodstream, causing a severe reaction. After delivery, doctors are always on high alert for postpartum hemorrhage, which is excessive bleeding, as well as placenta accreta, where the placenta attaches too deeply to the uterine wall, or uterine inversion, where the uterus literally turns inside out. I know, this list sounds absolutely intimidating, but the key takeaway here isn't to be fearful. It's to underscore the absolute importance of regular prenatal visits and just staying alert. If you ever experience sudden bleeding or notice a weird decrease in fetal movement, you simply call your doctor right away. No hesitation. Finally, Section 5, Medical Interventions and Solutions. Here is the truly reassuring part. When complications do arise, healthcare teams are incredibly well prepared. When a spontaneous vaginal delivery isn't safe or just isn't progressing, we have super reliable alternatives. We can use medications to safely induce labor if it needs to happen sooner rather than later. We can perform an operative vaginal delivery using precise tools like forceps or a vacuum device to assist the baby out. And of course, we can perform a cesarean delivery or C-section, which is a very common, highly safe surgical route to deliver the baby when a vaginal birth poses too much risk to either the mother or the child. As we wrap up this explainer, I really want to emphasize one thing. Serious problems during labor and delivery are relatively rare. And more importantly, your doctors, nurses, and midwives are highly trained, fiercely dedicated, and completely equipped to detect these issues early and treat them effectively. You are in very good hands. I want to leave you with this final provocative thought. Will you know what to look for when the unexpected happens? Education is absolutely your best tool for a healthy pregnancy. Understanding these mechanics doesn't just reduce your anxiety, it makes you an active, empowered participant in your own healthcare journey. If you found this explainer helpful, please hit that like button, share this with anyone who might benefit, and be sure to subscribe to the MediByte channel for more clear expert health explainers just like this one. Thanks so much for watching, and we'll catch you next time on MediByte.